Welcome to the second lecture on data quality and information governance. Technology is a critical tool in achieving high-quality data in an electronic health record and realizing the benefits of health information exchange. However, technology alone is not sufficient. It is imperative for organizations to hardwire patient safety and quality of care measures into their electronic processes and systems. Because data quality will positively impact the efficiency, quality, and safety of care, it follows then that a robust and high-quality EHR is required. Such an EHR then becomes an important adjunct to quality and takes its place as an evidence-based decision-making tool. In 1998, the American Health Information Management Association's EHIM workgroup developed the Data Quality Management, or DQM, model for implementing an EHR documentation improvement process. The model was reviewed and adopted again in 2006 and includes continuous quality improvement in the domains of data application, collection, analysis, and warehousing. In this model, the application is the purpose for which the data are collected. The collection includes the processes by which data elements are accumulated. Translating the data into a form that can be used for the designated purpose is part of the analysis phase. And you may hear this referred to as transforming data into information. And warehousing describes the processes and systems used to archive data indefinitely. And the model includes a number of data quality attributes that can be applied to each domain. The model is generic. It can be adapted to any care setting, used with any application, and can be used in any role that as an HIT professional would choose. Data quality is a complex topic and is affected by more than just the accuracy of the data. A review of the literature yields a number of terms that can be used to describe data quality attributes. The DQM model attributes include definition, accuracy, accessibility, comprehensiveness, consistency, currency, timeliness, granularity, precision, and relevancy. Each of these attributes will be described in this presentation. An example will be provided as well as key process issues that HIT professionals should consider for effective health information exchange. It is critical that data have definitions, so organizations should develop a data dictionary that represents agreement of all users on the standard definitions, normal and abnormal values, variable properties, etc., that are included in the data. During this process, it is essential that responsibility for oversight of the management of the data be assigned. We know and understand that data are often used for purposes other than that for which they were originally collected. It has been said that one man's junk is another man's treasure. Therefore, to support the multi-use of data that is collected, clear definitions for each data element should be provided so current and future users will know what the data mean. For example, does the word football mean the same thing to people all around the world? No. And without a clear definition that lets the user know what type of football we are referring to, errors in interpretation are likely. In addition, standard definitions are necessary in order to compare data with data stored in other databases. For example, external registries or quality databases, or to compare data over time, such as trend data for quality purposes. Each element should have a clear meaning and acceptable values. For example, in addition to clear definitions, a data dictionary should provide data type, length restrictions, and other rules including uniqueness, consecutiveness, or calculated data, and acceptable ranges. For example, should an EHR allow a temperature with 4 digits without a decimal point to be entered? Should numeric data be allowed where only text is expected? Inaccurate data can result from mistakes that are made when data are extracted, transformed, or transferred to secondary data sources. Well-documented data definitions and rules that govern accepted values can protect against inappropriate use of data. The federal health IT legislation described earlier requires that meaningful use of health information technology includes electronic reporting of data on the quality of care. When the Centers for Medicare and Medicaid Services were preparing to announce their final rules for the meaningful use standards and finalizing the list of core quality measures, one hospital had examined their opportunities for outcome reporting through a nationally recognized database for quality reporting. They decided to participate in the National Health Safety Network, NHSN, a voluntary secure internet-based surveillance system that is managed by the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention. Exchange of data through the NHSN requires adherence to the guidelines and procedures for data collection that includes specific definitions for all variables collected and reported. Let's consider an example of the importance of data definitions. An organization is preparing to participate in a nationally recognized surveillance system for public reporting of hospital-acquired infections. First, they review the definitions for all variables to be submitted to assure they match the definitions required by the database. Let's discuss how the attribute of data definitions can be applied to the data quality management model domains of application, collection, analysis, and warehousing. Appropriate use of the data requires an understanding of the purpose and data definitions. The data collection process should guide the user to enter only acceptable values and minimize or eliminate any ambiguity. Meaningful analysis relies on clear understanding of the data and making appropriate relationships among the variables. And warehousing requires assigning responsibility for the ownership and maintenance of the data and documentation over time, along with corresponding policies and procedures for data and information management. Accuracy is a term used to refer to the extent that the data properly represent the real-life objects they are intended to represent. Accuracy implies that the value is valid and correct, and the person who the value is related to is properly assigned. Inaccuracy can result from deficiencies and other attributes that we will be discussing later on. A lack of precision or completeness can also influence the accuracy of the data and the answers to the questions you intend to find to the use of the data. Remember, inaccuracy can lead to an understanding of a valid real-world state, but not the one intended. Let's consider an example of the impact of accurate data. Payment for care rendered is critical to the survival of any provider in all care settings. During the registration process, insurance information must be gathered and validated. You as an HIT professional can assist in improving the data quality in this process. By working with the business office personnel, you can establish a process to develop and maintain a reference table with the codes for all approved insurance providers. An automated process can be instituted to verify the accuracy of the insurance information by limiting entry to only those codes that are available in a drop-down menu that is linked to the reference table. Entry of any other data would require a process of verification and pre-approval for any manual entries for this field of data. A key process recommendation for you to enhance accuracy in the application of the data quality management model is to collaborate with users of the data to establish a policy or process to identify how data used in EHRs are generated and how data content will be determined and standardized. In an effort to improve data accuracy, you can prompt the users to think about purpose and application of the data and how choices in the data entry may be limited to improve the accuracy, maintain integrity, and improve the reliability and validity of the data. Accuracy in data collection can be improved by educating and communicating data definitions to those who collect the data. For example, if the time of initiation and discontinuation is critical for payment, the staff need to know exact, not approximate times that must be collected. You can also assist in accurate analysis of the data by ensuring that the algorithms, formulas, and translation software are correct. For example, one of the alternate quality measures to demonstrate meaningful use of electronic health records is childhood immunization status. You would meet with pediatric providers to discuss the purpose of this metric, the data elements that are collected, who will collect them, how the data will be applied to decision-making, and how the data will be transmitted to the immunization registry without losing data accuracy. Appropriate edits must be made to ensure accuracy prior to warehousing the data for future use. Exception and errors reports should be developed so that corrections to the data can be made. For example, some diagnoses or patient locations may be incorrect for the age or gender of the patient. Screening for these types of problems and making corrections will improve the accuracy. Accessibility is the extent to which data is available or easily obtainable for use. But easily obtainable does not mean that unauthorized individuals should be able to gain entry into protected personal health information. Accessibility incorporates ease of gaining entry with the safeguards that are absolutely required to assure confidentiality and privacy of patient data. These safeguards should be built into the process and automatically deploy without any special effort by the user. The Health Insurance Portability and Accountability Act, also known as HIPAA, includes rules, standards, and guidelines to guide you in establishing the appropriate procedures for health data access. The burden of data collection can often derail safety, quality improvement, and research efforts. Often the data that are needed already exist someplace within the scope of the electronic health record. A typical example of data that are often needed but shouldn't have to be collected again by clinicians are the demographics of a selected population of patients, such as home care patients with known congestive heart failure, who will be included in a quality improvement or research study. However, the detail and the use of this data must be evaluated for the patient's protection under HIPAA and other regulations. You can guide the team to select the best, least costly, and legally appropriate way to access and collect the data that are needed. The amount and accessibility of the necessary data can be increased through system interfaces. Inaccessibility of data can be a frustration to clinicians who need data to generate information about the ways to improve care. However, a lack of data stewardship also has serious risks and consequences associated with unauthorized access or inappropriate use of health information. Proper observation of the domains of the data quality management model requires you to work with clinicians to define and agree on the types of data and the minimum amount of data that needs to be available to support the team in achieving its mission and objectives. The intended application or use of data and the legal, regulatory, and financial boundaries often determine which data should be accessible. Collection of accessible data should be assigned based on the expertise and scope of practice of team members, with registration staff collecting demographics, clinicians documenting physiological findings such as symptoms or scale ratings, and coders assigning medical record coding. Data analysis should be supported by timely access to the required data. For example, if there is a recall on a lot of vaccines, care providers in a primary care office need rapid access to vaccine administration data to be aware of potential patients to be alerted to the recall. Policies should define the process, restrictions, and rights for retrieval of data from the database systems and warehouses. The accountability and chain of trust within HIPAA should be delineated. Organizations should be specific in their internal policies and business associate contracts about what identifiable health data may be used and for what purpose by both the business associate and its agents. Also, what HIPAA de-identified data may be used, to whom they are applied, the requirement that business associates have contracts with their agents that are equivalent to business associate contracts, and the use of HIPAA definitions for any de-identification of protected health information. Methods to regularly monitor and audit access to data should be in place. Comprehensiveness is the ability of an information system to reflect every possible state in the real world. Intentional limitations of the data should be documented, and every effort to include all of the data elements that are required is made. It is understood, of course, that not every piece of data can be captured, but many projects have suffered from lack of deep forethought about what and how to measure. A high level of missing data will reduce the reliability and validity of your analysis. In order to minimize missing data, rules can be assigned to a data set to define mandatory elements that require a value, optional elements that may have a value assigned based on some set of conditions, or inapplicable attributes that may not have a value. Comprehensiveness is illustrated in the following scenario. In October 2008, the Center for Medicare and Medicaid Services began requiring hospitals that receive federal funding from Medicare and Medicaid to begin disclosing never events. Never events are conditions that CMS defines as preventable and serious in their consequences for patients, and that indicate a real problem in the safety and credibility of a healthcare facility. Included in this list of conditions are pressure ulcers, or what is often referred to in layman terms as bed sores. CMS has stated that they will no longer reimburse hospitals for any costs associated with never events, and hospitals are prohibited from passing the costs on to patients. The ability to differentiate conditions that were present when the patient was admitted versus those that were required during the hospital stay requires a comprehensive assessment and documentation as a means to avoid potential penalty and quality concerns. Increasingly, clinicians are turning to health information technology professionals to assist them in defining data elements and rules for their completion for clinical, financial, and risk management needs. Key process recommendations to apply the attribute of comprehensiveness within the context of the data quality management model is for you to seek clarity from the team about how the data will be used and how end users can assist to ensure the complete data will be collected. Opportunities to create interfaces with other automated systems should be pursued. When doing so can enhance the comprehensiveness and quality of the data collection. An example of this might be to link the skin assessment completed in an emergency department's electronic health record from one vendor to the skin assessment completed in an inpatient electronic health records made by a different vendor. The goal is to make the collection of the necessary data elements as comprehensive and as seamless as possible across care settings. Be alert to the multiple places that the same data element might be recorded and attempt to reduce the variation in data completeness. Whenever possible, provide structured response choices and reduce the number of free text entries to facilitate complete entry and extraction. You should recommend that all relevant data are collected and analyzed in concert. For example, in addition to assessing whether or not pressure ulcers were present on admission, the team may also want to know about risk factors to aid in a comprehensive assessment of the quality problem if a number of patients later develop ulcers. In warehousing data, be aware of and educate all data stakeholders of the data that are available to prevent redundancy and conflicting data collection. The term gold standard often comes to mind in the discussion of the attribute of consistency. The value of the data, or the representation of what the data mean, should be reliable and mean the same thing across applications. The same data element, when drawn from two different places, should not conflict. Often in the subjective measures or complex concepts, a preferred definition or set of conditions must be provided in order to guide the user in how best to judge the real world state and record the correct data value from among the possible choices. It is important to note, however, that data can be consistent and still be incorrect. For example, a primary care provider's patient roster and billing data may note a patient as a correct current patient when they have, in fact, transferred to another provider. Consistency does not always equate to accuracy. Consider this example. Allergy status is an example of an issue related to consistency that crosses all types of care settings. Consistent information is not only important from a data quality perspective, it is important to assure patient safety. The issue of allergies can be complex and can involve several levels of questioning to arrive at a conclusion. Within a particular care setting and across interface systems, the question can be standardized and users can be educated on the guidelines so that the data are consistent across all areas and across time. A recommendation for you to improve data quality is to assist the team in identifying if a gold standard exists to improve consistency in the use of the data. This process also involves determining if there is a true owner of the data who has the final say in determining the phrasing for the data element or who has the final editing rights. Auditing for inconsistencies across interfacing systems or across the stays or encounters for an individual patient can aid the team in their assessment of data quality for an important safety concern. Consistency in the collection of data may require user training and standardized data collection rules. Analysis requires monitoring consistency of the data elements to ensure that a valid comparison of data elements can be applied. The data warehousing process may require edits and conversion tables to facilitate consistent interpretation and use of the data for any element whose definition may be changed. System currency is judged based on how well it reflects the current world. Currency means the data are up to date, and the information is correct despite time-related changes. The data are up to date if they are current for a particular point in time, and outdated if the situation changes and the data are no longer correct. The term decay can be used to describe the temporal aspect of data currency quality. Data values can be accurate when entered but become inaccurate over time. For example, a blood glucose drawn in the past is current only for the date and time the sample was taken. it should not be assumed that the value is current for any other point in time. Here's an example of data currency. The International Classification of Disease, CM version 9, is the official system of assigning codes to diagnoses and procedures associated with hospital utilization in the United States prior to the ICD-10 version. In addition to their use for billing and reimbursement, these readily accessible coded data were often used to evaluate comorbidities and potential hospital-acquired conditions for quality studies and research. The ICD classification scheme has been revised periodically to incorporate changes in the medical field. The current version, 10, became effective October 1st, 2014. All tables used to map the codes and crosswalks needed to be in place for the transition. Teams needed to be aware that the use of the codes before and after and during the transition were properly mapped to the correct definitions in order to assure currency of the data and the analysis. System currency is judged based on how well it reflects the current world. Currency means the data are up to date and the information is correct despite time-related changes. The data are up to date if they are current for a particular point in time and outdated if the situation changes and the data are no longer correct. The term decay can be used to describe the temporal aspect of data currency quality. Data values can be accurate when entered but become inaccurate over time. For example, a blood glucose drawn in the past is current only for the date and time the sample was taken. It should not be assumed that the value is current for any other point in time. Here's an example of data currency. The International Classification of Disease, Clinical Modification version 9, was the official system of assigning codes to diagnoses and procedures associated with hospital utilization in the United States. In addition to their use for billing and reimbursement, these readily accessible coded data are often used to evaluate comorbidities and potential hospital-acquired conditions for quality studies and research. The ICD classification schema has been revised periodically to incorporate changes in the medical field. Version 10 became effective October 1st, 2014. All tables used to map the codes and crosswalks needed to be in place for this transition. Teams needed to be aware that the use of the codes before, after, or during the transition were properly mapped to the correct definitions in order to assure currency of the data and the analyses. As the real-world state changes over time, the values and the purpose for which the data are collected will also change. As a health information technology professional who is astute in preserving the quality and accuracy for reliable use of data, you will work with a team to establish requirements and provide definitions for the currency of each type of data. Documentation of the rules and logic that were used for the data collection should reflect any changes or modifications that have been made over time, so users of the analyses have a clear understanding of what the values and results of any analyses mean. Warehousing will involve continually updating tables and maintaining lookup and crosswalks with clear documentation of when data changes occur. While currency means that the data represent the world at the time they are captured, timeliness is more closely related to the accessibility and availability of the data for use when needed. Data are timely if the data are processed for use in time to conduct business and facilitate decision-making. Here is an example of the timeliness of data. An electronic bed board is an automated method to track and communicate patient locations. They are replacing older paper and telephonic tracking systems. When it was originally implemented, the only interface that was built was the patient registration system to provide a daily midnight census download. Over time, interfaces with other systems such as pharmacy, laboratory, dietary, and other ancillary services systems have been built. The increased demand for current data about patient location has required more timely updates to the system to conduct daily business and inform the decisions that are made related to patient care and census management. Application of the data quality management model includes working with the team to establish standards or policies for the timeliness of the data collected and stored in relation to key events. Timeliness is defined by the use of the data. For example, hourly or daily census data may be needed to support decisions such as budgeting or strategic planning. The use of the data will also drive the standards for the frequency and processing of data collection and warehousing. Timely analyses allow for the opportunity to monitor progress and to make course corrections to avoid negative outcomes. Data granularity is the degree of detail that is represented by the data, where the greater the detail, the finer the granularity. Depending on the requirements, multiple levels of detail may be present. Granularity in measurement refers to the intervals in either space, such as inches or feet, or time, such as seconds or hours. If data refer to entities sorted into categories, granularity refers to the choice between a larger number of narrow categories, such as ICD category, or a smaller number of categories, such as DRG codes. Quality in this attribute means striking the proper balance in the level of detail needed. The granularity of the data should not become so detailed that it is neither useful nor compatible with other systems to which the data may be transmitted or stored. Take this example. The Institute for Safe Medication Practices, known as ISMP, is the only nonprofit organization in the United States committed totally to medication error prevention and the safe use of medications. It regularly publishes alerts with lessons learned to assist the healthcare community in identifying potential pitfalls to avoid and safe practices to implement. One of the very first alerts issued by the ISMP was to caution providers about the expression of a decimal without a leading zero. An example of this type of error can be found on their website. It describes the death of a 9-month-old infant whose order for a 0.5 milligrams of morphine without the leading zero was interpreted as 5 milligrams, resulting in an overdose and death. Misinterpretation of decimal points and other dangerous dose expressions and abbreviations continue as a source of medication errors, causing tragic results for patients, their families, and unsuspecting healthcare providers who have made these mistakes. Proper programming and identification of the appropriate levels of granularity in health information technology are intended as safeguards to prevent these types of errors. Care should be taken to avoid these dangerous abbreviations and dose expressions in other communications such as computer-generated labels, medication administration records, labels for drug storage bins and shelves, pre-printed orders and protocols, and pharmacy and prescriber computer order entry screens. Hierarchy is a logical structure that uses ordered levels as a means of organizing data. Aggregation of data can be defined in terms of hierarchy. For example, if we think about time or sequence as a dimension, then a hierarchy works to aggregate data on a yearly, quarterly, monthly, or daily level. Within a hierarchy, each level is connected to the levels above and below it. Data values at lower levels aggregate into the data values at higher levels. The purpose and use of the data may require different levels of detail. The process of data collection requires thoughtful determination of the appropriate level of granularity for the task at hand and the outcome analyses that will be completed. For example, granularity of age may be defined as days for neonates, as months for infants, and years for those 1 year old or greater. These determinations will follow through to the level of granularity that is appropriate for the data that are warehoused. Precision refers to the degree to which repeated measures yield the same result under unchanged conditions. Precision, or reproducibility, is essential in order to allow for valid comparisons. Quality and precision means that the data value should be just large enough or contain just enough detail to serve the intended purposes. Note that precision is not intended to be applied only to quantitative data. It can also refer to the descriptive terms used to represent qualitative data. For example, the meaningful use core clinical quality measures for primary care providers includes preventive care screening for over and underweight conditions in adults. In order to meet the quality measure and qualify for possible incentives for patients 18 years old or older, there must be a calculated body mass index, or BMI, documented in the patient's medical record in the past 6 months or during the current visit documented in the medical record. In addition, if the BMI is outside of the identified parameters, a follow-up plan must be documented. The BMI requires information about the patient's current weight and height. Knowing that neither of these are measures that people self-report with a high degree of accuracy, it would be more precise to obtain these measures and record them rather than rely on self-reported measurements. Another strategy to increase the precision of this measure is to reduce the factor of human error in the calculation and to program automatic calculations of the data with automatic alerts when follow-up is required based on the established action parameters. Care should also be taken to complete these measurements with devices that are reliable, as evidenced by documented periodic calibration checks. Your knowledge can be used to guide the team to clarify the purpose and intended uses of the data and the questions that need to be answered. As discussed in several of the other data attributes, you will need to identify what level of detail is required, what the appropriate ranges for each element should be, and what categories of data elements will be needed for data collection. It is important to remember that accuracy is the degree of truth and precision is the degree of reproducibility. There should be a validation or quality checks to determine if data analyses elicit the same or similar results and contain the needed level of detail when compared to past reports using the same data. Precision of the data must be demonstrated prior to storage and an extraction from the data warehouse. Relevance means that data are meaningful or applicable to the performance or purpose for which they are collected. Every piece of information collected and stored should be important and provide information and value to the business at hand. If it is unclear how the data are to be used, the highest level of detail should be provided. Giving careful scrutiny to the relevance of data can build trust in the data, enable key processes, increase the accuracy of analyses using the data, foster support for decisions made from the data, and optimize performance of the database. Take this example of the importance of data relevancy. A multi-specialty medical practice group implements an electronic health record with a number of product features. In addition to registration to support billing and coding, it includes standardized history forms and progress notes, clinical reminders, and pharmacy and laboratory interfaces and reports. Members prioritize the critical decisions related to the customization, pre-implementation, and determine that they will go with the out-of-the-box standard version of the clinical summary. However, 2 months after implementation, when each member has had the opportunity to determine the usefulness of the summary, they realize the ever-growing amount of clinical data that is accumulating for each individual patient. Knowing that one of the most critical tasks they must perform is to sort through large amounts of data to find pertinent information, they seek the opportunity to optimize the usefulness and relevance of the clinical summary. They determine the information that is relevant to all clinicians and supports the business needs of the practice for routine inclusion in the summary, and allow each provider to customize the report to include the data pertinent to their specialty, which allows each user to answer clinical questions and support his or her clinical decision-making. To summarize, data is used for a variety of purposes, but data used for research purposes is collected under different conditions than data collected for quality improvement. It is clear that poor data quality contributes to error in healthcare settings. This presentation reviewed the 10 attributes of data quality that make up the data quality management model, including definition, accuracy, accessibility, comprehensiveness, consistency, currency, timeliness, granularity, precision, and relevancy.